Post-operative pain assessment and management by Guadalupe Reboso. Chronic pain. Chronic pain also places a significant burden on the economy, costing Australia an estimated $34.3 billion per annum, with productivity costs of $11.7 billion and health systems costs of $7 billion. To the cause of chronic pain. Patients with acute pain but later turning into chronic pain and insistent after 12 months post-surgery. Nurses report pain by handover and the important role it has when handing over from doctor to nurse and nurse to ward. This is important as introduction of the post-anesthetic care tool PACT. Associated with improvement nursing management of patients in the post-anesthetic care unit PACU, and enabled early identification and response to clinical concerns, post-operative complications. Assessment of temperature increased. Knowingly, more patients had an assessment of nausea and vomiting documented in the post-anesthetic care unit. Notes and more antiemetics were administered in response to the assessment. Documented rates of many adverse events increased significantly after the introduction of the PACT. This is a positive outcome, indicating that the tool enabled nursing staff to better recognize and respond to deteriorating before the patient's condition became critical. This finding is consistent with the Australian study that demonstrated an early increase in rapid response team calls following the introduction of new documentation and the importance of addressing the patient's long-term recovery needs. Nurses' use of the subjective and objective data from the patient when assessing pain. Tools that are used when observing and gathering information according to the patient's needs, and the request of pain measurement done by the pain management team is the verbal rating scale VRS, numerical rating scale NRS, visual analog scale VAS. The overall concept underlying post-operative acute pain relief is multimodal or balanced analgesia. That is the use of combinations of analgesic or analgesic techniques with different modes and all sites of actions. Such an appropriate combining a non-opioid with an opioid or a regional anesthesia technique with a systemic analgesic. This improves pain control compared with mainly opioid-based analgesia and reduces opioid consumption. Providing suitable analgesia is only one of the several fundamentals of enhanced recovery after surgery protocols aiming to reduce hospital stays and complication rates. Patient-controlled analgesia (PCA). Opioids remain an important component of universal analgesia for the release of severe pain. In the early postoperative setting, intravenous opioids delivered via PCA provide better analgesia and results in greater patient gratification, which also leads to the use of non-pharmacological methods to treat pain and education, such as cold approaches such as ice packs in orthopedic wards, acupuncture for a more holistic approach, and relaxing therapy and distraction, as this can assist with the patient's cognitive state and distract them from thinking about the pain for a short period of time. Other forms also include multidisciplinary pain management. This addresses the complex physical, psychological, and environment influences that contribute to the pain experience. The multidisciplinary team usually includes a physician, nurse, psychologist, psychiatrist, physiotherapist, or an occupational therapist, and a pharmacist who have all training in pain management to provide the care for the patient and to an overall pain working together as a team across all sectors. A patient-specific tactic to pain management is recommended, enabling earlier rehabilitation and reduced hospital stay. There is an increasing evidence of an association between the severity of the acute pain and the risk of developing chronic pain, post-operative pain. Regarding patient information, pre-operative, yet many patients appear to lack knowledge as to how they will advance through surgery and recovery. This is particularly true for operations that are fatal, where detailed pre-operative advice is not taken because of the overwhelming nature of the diagnosis. There is a monumentous degree of inconsistency in written post-operative advice provided to patients in Australia. Individual surgeons and hospitals should provide specific and tailored advice directly to their own patients. Lack of education towards the patient's pre-operation. If there was a better educational information given in the written and verbal information provided together, has been found that patients retain only 20% of information given verbally, but this can be increased to around 50% if written information is also provided. Social disadvantages and access to interdisciplinary pain services is restricted for rural and remote residents, Aboriginal and Torres Strait Islander communities, and other culturally and linguistically diverse Calc populations. Some written resources have been translated into different languages, but this is very limited. Evaluating pain across cultural gaps can be challenging, which is important to have a strong care plan in place for patients. Many patients not cooperating and not responding to the management of pain plan. Many refusing to use of analgesia. They do not agree with the use of analgesics, and many refusing to cooperate and identify if they are in pain to avoid the usage of analgesia. Formal training in pain management. A statewide approach to clinical training and education initiatives in pain management should be appreciated. Facilities cannot meet patient demand with existing resources, and few are entirely capable of delivering evidence-based practice. Some nurses require additional resources to provide a sustainable service. With improved pain management services, nurses should be able to provide timely care for the patient's needs. The results show that nurses miss the opportunity to include the patient's self-reported pain in their accounts. This is also since nurses are time-consumed. Missed care may be related to such challenges as financial and time limitations, with the focus on shorter hospital stays. A study in New South Wales found that nurses spend only 30% of their time in direct patient care. Teamwork. Though it has been reported as one section preventing nursing care being missed, it was shown to be an important factor in the variation of missed care in hospitals having similar nursing staffing levels. This is the cause of lack of involvement or the availability of staff to be able to provide the care needed and the staffing available for the number of patients needed, staffing rations, and poor time availability between patients. Post-operative pain is important. It needs to be articulated about, as it leads to patients leaving the healthcare system only to return, but to also live a life of chronic pain when they could have been better managed before leaving the hospital. Closing the gap by developing an easier way of communicating within the team and involving the patient that allows all information to be delivered, such as a handover developed for that ward to assist with their patient's needs, which are different to others, and the improvement of teamwork and support with the nurses to assist and identify the best way of care for a patient suffering from post-operative pain.